Well, thank you very much. It's a great pleasure to be here. So I thought what I'd do today is actually talk about cranium spinal dysmorphism and its association with cerebrovascular diseases. But I want to focus in particular about the venous anomalies and the ones that you see in Arnold or Chiari malformations. So these are my disclosures. So the things I want to talk about first is give you an introduction into what are the venous anomalies that you can see with Chiari malformations. Then I want to talk about whether these malformations or abnormalities are actually clinically significant. I also want to talk about pathophysiology. Is there a common link that allows dysmorphism to coexist with venous anomalies? And the last thing I want to talk about is this theory about venous compression as a consequence of elevated intracranial pressure. So in terms of venous anomalies, we all know what Chiari malformations are, and we all know the types of Chiari malformations that exist, all of them having in common tonsillar herniation. But one thing that actually has gained attention over the last few years is the presence of concurrent venous anomalies. And some of them that actually have been identified is the presence of significant stenosis or even occlusion of the transverse sinus, sigmoid venous sinus, and even internal jugular vein. And also presence of collateral circulation, which may be a consequence of the stenosis or occlusion in the form of condylar veins, and even transosseous emissary veins that you wouldn't see in normal individuals. And these are some of the examples of venograms that were done in patients with Chiari malformations that highlight some of these venographic abnormalities. For example, in this particular patient, you're seeing an anterior-posterior projection, and what you notice here is you really don't see a transverse or a sigmoid venous sinus on the side that the contrast is actually injected. And most likely that represents a stenosis or an occlusion, but as all of us know, we cannot exclude the possibility that this may be some form of a hypoplasia. Now this is actually another patient, and if you look at the lateral angiogram, you do see the sigmoid sinus, but you would actually notice that the internal jugular vein is substantially attenuated in terms of contrast and probably represents a stenosis or hypoplasia of the internal jugular vein. Now, we also know that these findings can be seen in normal patients. And there was actually this study that actually looked at patients with Chiari 1 malformation and the prevalence of transverse venous sinus stenosis and compared it to normal controls. And if you look at the rate of venous stenosis, it's actually 5-fold higher in patients who actually have Chiari malformation. So it does suggest that there is actually a higher prevalence of such abnormalities in patients who have Chiari malformations. Now we also end up seeing collateral formation, which probably is a consequence of the stenosis or the occlusion. For example, you can actually see these transosseous emissary veins. In this patient with Chiari malformation, you can actually see the sigmoid sinus and the transverse sinus, and you also see prominent transosseous veins that are actually going through the occipital bone. And similarly, you can see smaller transosseous veins in another patient who actually is presenting with Chiari malformation, and this is a lateral venographic image. And what is not clearly understood, and this is actually sections of the occipital bone with casting according to color. So the red color represents the arterial channels within the bone, and the blue color represents the venous channels. And the occipital bone has substantial amount of these venous channels in a normal normal occipital bone. And these are usually the diploic veins that originate from the transverse sinus and sometimes the sigmoid sinus. And what is not known is that in the event of a stenosis or occlusion, whether these are channels that actually become activated or these diploic veins simply undergo angiogenesis that allows these collaterals to connect the sinuses to the external venous drainage systems. Now, there is a substantial amount of collateral formation that you can actually see at the base of the skull in patients who have Chiari malformations. For example, in this patient with Chiari malformation, you can actually see the stenosis of the internal jugular vein. And you end up seeing another venous channel that connects the sigmoid sinus or the terminal sigmoid sinus to the external jugular vein. And in this particular patient, this is another patient with Chiari malformation. And if you look at the anterior-posterior projection and the venographic images, you would notice that there is substantial connection between the sigmoid sinus and actually the paravertebral venous plexuses. And once again, just highlighting this concept of numerous collateral channels that actually are in the vicinity of the jugular foramen, are connecting the sigmoid sinus to other circulations beyond just the internal jugular vein. And it is not uncommon for people to actually have two prominent connections outside the classic sigmoid sinus internal jugular vein connection. One is actually an anastomosis that connects the terminal sigmoid sinus to the paravertebral plexus, either through a foramen or actually may sometimes be below the jugular foramen. And similarly, another venous connection that allows the sigmoid or the terminal sigmoid sinus to connect with the external jugular vein. And in patients who actually have Chiari malformation, some of these collateral channels are far more pronounced, either because of a primary phenomena or secondary to the stenosis or occlusion of the internal jugular vein or the sigmoid sinus. And you can see these substantial collateral channels that actually can be seen despite a patent internal jugular vein. So these are actually some of the venous abnormalities or anomalies that you can see with Chiari malformation. Now the question is, are these just angiographic findings, or they actually contribute to the symptoms of Chiari malformations? And in theory, you could hypothesize that they actually contribute to the symptoms of Chiari malformation. Essentially, an occlusive disease at the distant or the terminal sigmoid sinus or the internal jugular vein would lead to venous engorgement, which you can actually sometimes see, particularly in the posterior fossa. And that itself could lead to intracranial hypertension or exacerbation of intracranial hypertension that one can see with CSF outflow obstruction. And similarly, since the cerebrospinal fluid drains through the arachnoid granulations into the dural venous sinuses, an occlusive disease of the dural venous sinuses could actually worsen the hydrocephalus that sometimes is associated with Chiari malformations. Now, we just talked about two phenomena, the Chiari malformation and then the venous anomalies. What makes these two coexist? Are this a chance phenomena, which we don't think so, given the higher prevalence in patients with Chiari malformations? And there are actually two theories for that. One is that Chiari malformations can be precipitated by certain causes like craniosynostosis, neurofibromatosis, that can lead to a delay or even impairment of development of the posterior fossa. But these abnormalities can also affect the venous channels, independent of the Chiari malformation. The other thought is that the Chiari malformation is precipitated for various reasons, but nonetheless the abnormal formation of the posterior fossa, particularly the skull bones, which influence the development of the venous parts of the posterior circulation, actually and continue even after birth, are impaired because of that interaction or that defective interaction between bone formation and venous channel formation. So we are left with two theories. One is the common root theory, that one event precipitated both of them, or second, the Chiari malformation came first, and the venous abnormalities are actually a secondary consequence of the Chiari malformation. But I actually want to talk about another hypothesis, which I don't think would have been possible till some recent research that has actually shed some new light into the embryogenesis of some of the components that are involved in Chiari malformation. Well, all of us know there is the neural tube that's responsible for the tube closure, the rhabdomeres, and then there is the neural crest. And the neural crest actually has the outer ectomeninge, which is responsible for the dura mater formation. So all the dura and the dural venous sinuses are derived from the ectomeninge, which is really a neural crest derivative. Now, for many years, it's been believed that the rest of the posterior fossa development is a consequence of the paraaxial mesoderm, which through the occipital somites really contributes to the caudal development of the skull. So essentially, to link them on an embryogenic basis was not possible because there were two different derivations of the venous sinuses and other components of the posterior fossa. But now with recent ability to tag tissues and ability to actually identify the origin of a particular cell line, what it seems like is that neural crest is really the origin for not just the ectomeninge, does not only provide the dura, but also provides the bone or the skull components that are part of the Chiari malformation. So now an embryogenic hypothesis becomes more feasible because it's really a common origin. And that, I think, is one of the things that actually would suggest that if there is an abnormality of the neural crest that leads to Chiari malformation, it is quite possible that the neural crest that forms the dura is also resulting in the venous anomalies that we just talked about a few minutes ago. And that actually brings us to the embryonic link theory, where essentially, depending on where the neural crest is affected, you may actually see the manifestations of Chiari malformation, but also see the venous anomalies that we just talked about in the past few minutes. And depending on the cascade, if essentially the abnormalities start at a later phase, you would really be seeing a Chiari type 1 malformation. If you're actually seeing abnormality of the neural crest cell at an earlier phase, you probably may be seeing Chiari type 2 to type 4 abnormalities, where tube closure abnormalities and even agenesis may be essential components of the whole syndrome. The last thing I want to talk about is venous compression. Because there is a prevailing thought that the narrowing of the dural sinuses, which we have been thinking is actually occlusive disease or stenosis, is really not stenosis, but actually external compression that is giving the impression of narrowing and almost just simply mimicking a stenosis. And the thought process is that since there is obstruction to cerebrospinal fluid outflow, there is intracranial pressure elevation, and that leads to compression or secondary compression of the dural venous sinuses that end up giving an impression of a stenosis, but it really is just external compression. Now, to further determine whether even a compression of dural venous sinus is possible in the face of elevated intracranial pressure, we did some cadaveric experiments. And these are actually MRIs of cadaveric brains taken at different stages of intracranial mass lesions, really to kind of determine volume expansion within the cranium and essentially its effect on compression of the dural venous sinuses. And essentially on this lateral view, the veins are actually highlighted on the MRI in blue. And if you actually place a balloon within the cranium and increase the volume of the balloon, you can essentially see that there is no compression as long as the volume is around 50 cc's. But when you go to larger amounts of inflation in the cranium, now you do start seeing obliteration of the venous sinuses. And similarly, if you're looking from the posterior aspect and looking at the transverse sinuses and the confluence of sinuses, once again, you would notice is that really your compression or intracranial mass lesion has to be at least 90 cc's before you'd see any distortion of these venous sinuses. And if you put a manometer within the sinus, if the superior sagittal sinus, you put a manometer, and then just measure the pressure while you're increasing a mass lesion in the supratentorial compartment, you would notice that there is no change in pressure as long as the mass lesion is around 120 cc's in the supratentorial compartment. And then you start seeing change in pressure when the mass lesion exceeds 150 cc's in volume. And that's actually an exponential increase in the vein or pressures within the vein. And you can see dramatic increases when the volume of the extrinsic lesion within the supratentorial compartment is around 200 cc's. So yes, there can be distortion and there can be compression of the venous sinuses, at least in cadaveric models, when there is mass effect and intracranial hypertension within the cranium. However, we also have to acknowledge that the dural venous sinus compression occurs in the presence of substantial mass effect and very high intracranial pressures, which we think, at least with the evidence that we have today, are unlikely in Chiari malformation patients. So I think that that does actually bring us to a conclusion, or not a conclusion, at least a thought process, that perhaps the venous compression or the secondary venous compression theory probably has little bearance as it stands in Chiari malformation. Now I know that the time is short, so I really wanted to focus on some of the elements that I thought were most pertinent to this concurrent existence of venous anomalies and Chiari malformations. I'd like to conclude here with the following statements. I think that cerebral venous sinus and internal jugular vein stenosis and occlusion with secondary collateral formation is relatively frequent in patients with Chiari malformation. But what we don't know or don't understand is that whether treatment, which today is available, of these stenosis or occlusion and actually improving the lumen diameter of these narrowed or occluded blood or venous vessels can actually result in symptomatic improvement in patients with Chiari malformations. So those are some of the facts I wanted to talk about, and at this point, thank you very much, and any questions would be greatly appreciated.
Thank you very much, Dr. Qureshi. I'm sure there are comments. Dr. Ricate.
Yeah, you have a couple days. That was really quite a good talk. The issue, though, is what you're looking at in one way or another is pseudotumor, and what happens in pseudotumor is the brain gets bigger because it's like an erection, and so the venous outflow, what you're seeing with those transcranial veins is clear evidence that it's been long-standing increased pressure in the veins, and that could have caused the Chiari. But I don't think you should throw the baby out with the bathwater about these temporarily, because it's a positive feedback loop, and it has been shown that if you stent them, you can help or even treat the pseudotumor, even though they go away when you drain CSF. This is an extraordinarily important part of the picture, and I wish you well. I think this is a good start, and I'd like to work with you.
Dr. Rigamonti, you have any comments?
Well, I would like to echo Dr. Rickett. I feel like, do you have intracranial pressure monitoring in this patient? Because I wouldn't be surprised if it's elevated. And if that is the case, it would confirm what Dr. Rickett just said, that frequently Chiari is associated with pseudotumor, about 20% of the cases, because intracranial pressure increase causes engorgement of the tissue, and therefore the tonsils may herniate down. So I think that they're very related, and measuring intracranial pressure is critical.
Any other comments? Dr. Kula.
Do we have any evidence about what just happens looking at these studies pre and post operatively? You decompress the posterior fossa, the veins open up without stenting them? And do you know anything about that?
That's a very good question, and I don't have any data on that, and I think that that's something we should definitely look at, whether some of these changes just regress with actually relieving some of the acute compressive changes of Chiari malformations. And I think that the second comment is very valid too, that we've never really done transvenous pressure measurements in patients who actually have Chiari malformations. One of the theories that in at least one of the studies was that, yes, these abnormalities develop, they are long-standing collateral channels, but by the age of 6 years, that was hypothesized, that these collateral channels have already stabilized the venous drainage system. So yes, these are abnormal, but not necessarily physiologically causing any outflow obstruction.
Well, there's a case, there have been two cases. One was from the Hospital of Sick Children in Bay Ormond Street. The patient was having a craniofacial procedure, and a emissary vein was taken with bone wax, and the patient died instantly. Yeah, and or Aprit's, I think, but Pfeiffer's, I think, but one of those. And so they continue to try to recruit the vessels. It makes the surgery in these patients very, very tricky. But yeah.
Dr. Henderson, you had a comment?
This is related. Perhaps you could offer some intelligence to this quandary, but we had 10 patients with Ehlers-Danlos syndrome. Most of them had borderline Chiaris which had been decompressed. And all of these patients appeared to have high pressure in the head and some visual changes. And when we did a CT venogram, we found what looked like compression at the level of C1, compression of the jugular vein. And so I sent them, over the course of 2 years to William Banks at the hospital center, and he did angiography. And he found no gradient of pressure between the transverse sinus and the upper and lower jugular. There was no gradient despite the appearance of a stenosis. And I recognize that you were talking about intracranial stenosis. This is an extracranial. But there was this, I said, well, what was the venous pressure? And he said, well, it was, about 14 to 20. And I know from, residency days, having put in several hundred subclavian catheters, that the normal pressure in the jugular should be less than 5, And so in all of these patients, the venous pressure was elevated, and that was being transmitted all the way up into the intracranial cavity, which made me then think that we may be dealing with a form first of a diastolic syndrome. I was wondering if you had any comments on that.
I think that that's a definite, it's a very valid point, and in somebody who has limited intracranial compliance that some of these patients do, even a small increase in the venous pressure could have significant consequences intracranially.
Do you often see patients with elevated venous pressure when you do the stenting?
Yes. So,
what sort of pressures do you see?
So essentially, in terms of absolute pressures, and particularly a lot of this data comes from our experience with idiopathic intracranial hypertension, the average pressures that we see are usually in the order of 15 to 20 millimeter intracranially. And it would seem a little higher, but it probably is a reflection of just these patients, the patients with intracranial hypertension probably just having a global increase of pressure that's probably just being transmitted to some extent. What we have found most helpful in terms of determining whether there is physiologic significance to a stenosis or not is the gradient. So if you can actually measure pressure proximal to the stenosis and you're measuring a pressure of, let's say, around 20 millimeter, and then all of a sudden you measure it distally and the pressure is like 5 millimeters, so that gradient probably gives us more information in terms of the physiologic significance of the stenosis. But I think that you're absolutely correct that we don't really know what the normal physiologic pressure in these veins should be. And what is actually more interesting is that it is very positional. And all this anatomy that I showed is people who are lying in supine position. And now we have evidence that if these people were standing up, this whole venous drainage system would look quite different. So I think that there is so much that we are starting to learn about the venous system that we just didn't know.
I'm going to take a crack at that, Fraser. We have measured venous pressures in the sinuses in over 200 patients. And the obese women have very high right atrial pressures that are transmitted upward into the venous system, and that's the cause of the pseudotumor. But there's a group of, and they were all children, ages about 4 to 10 or 15, that had syndromes of some sort. I can't remember they were weird syndromes, and the question was, did they have pseudotumor? And they did have pseudotumor, and they had very high right atrial pressures as well. The cardiologists never would believe it, and they would do these ultrasounds of the heart, and they say, no, it's not high. And yet, when we did a catheter study, they were very high. So I think that comes into the thing that maybe EDS is one of those syndromes that can cause, and I suspect that it's a form first of primary pulmonary hypertension.
Thank you. I think thank you very much. That was
so
very
much.
thought-provocative.